So Tim, brain mets are certainly very common in these patients, especially ALK fusion patients tend to have a higher incidence of these brain mets. Do you screen them often? Do you manage them with SRS, gamma knife? I mean, what's your approach for the brain mets in these targeted therapy patients?
Yeah, I mean, there was some concern with the first generation, and some early reports that the discordant responses warranted earlier brain-directed radiotherapy. We've become far more comfortable with, osimertinib and alectinib and such, doing surveillance. So, I often see these people, and then we're getting scans at 1 month just to make sure they're responding, and then backing off to Q3 to 6 month MRI scans, and hopefully instituting radiosurgery if they start to have localized progression. I'd put a plug in as well for the recent hippocampal avoidance study that came out, which is making a whole brain radiation, although we're still loath to use it early, a more tolerable approach if we have to use it for diffuse progression at a later time.
So for most of these patients, now that the EGFR and ALK therapies have such good brain penetration, you tend to just observe them initially?
Yeah, I mean, the challenging scenario comes in is if someone presents with symptomatic or larger, bulkier lesions, and you're waiting for the targeted therapy. They're a non-smoker, and you're not sure if you should institute radiation and hope or wait and hope. So that can be a challenging clinical scenario. It's not as challenging if it's radiosurgery option, because you're not as concerned about long-term toxicity. But if it's a burden of disease that's either whole brain radiation or nothing, you hope you can wait and use a targeted